Today, we're going to spend the next 45 minutes or so talking about MIGS, or minimally invasive glaucoma surgery, and evolving non-traditional glaucoma treatment options for the anterior segment surgeon. My name is Kevin Barber. I am an anterior segment surgeon from the East Coast of the United States in Orlando, Florida, and I'm the president of the Advanced Center for Eyecare Global. These would be my relevant financial disclosures for today. I am a consultant for Alcon and Trek, and I have been principal investigators for the FDA clinical trials for Glaukos, Ilios, Trek, and Alcon. So the learning objectives for the next 45 minutes, or what this lecture will be about, is a comprehensive, as possible, review of MIGS and drug delivery technologies that are either currently available or will be coming available to the anterior segment surgeon in the near future. Now, this, in full disclosure, is coming from my perspective as a practitioner in the United States, and I'm fully acknowledging that MIGS is new enough that it hasn't been fully globalized. So I understand that there might be MIGS procedures available in other parts of the world that we don't have here in the US or Europe. I've tried as best as possible to include every technology that I'm aware of. And I'm also acknowledging that some of the technology that we have here in the US is just not available in other parts of the world. But I think the point of this lecture is to give a comprehensive review just so you're aware of what's available now and what's coming, because I do believe that this is the future wave for many anterior segment surgeons. Now, this lecture will not be an exhaustive talk on data or outcomes. There's not a lot of data on the comparison of MIGS or drug delivery devices. That would be several more hours of lectures altogether. So we're not going to do a deep dive into all things MIGS, but more of staying on the superficial level. I'm going to show a lot of surgical videos just so you can get a glimpse of what the MIGS space looks like now. So if we think about traditional glaucoma treatment, as you all know, we start with eye drops. If eye drops are not sufficient, oftentimes, if there's availability, we'll go to an SLT laser. And then from there, we would jump to incisional surgery of trabeculotomies or tubes. So the MIGS, or the minimally invasive glaucoma space, and the drug delivery space is attempting to bridge the gap between the conventional conservative treatment of drops and SLT and more invasive surgeries like tubes and trabs. So we're talking about patients with mild to moderate glaucoma, most of which are undergoing cataract surgery. So a lot of MIGS and drug delivery is being tied to cataract surgery, although it can be done independently of cataract surgery. But it's trying to take those mild to moderate glaucoma patients and lower the risk of them going on to needing more invasive surgeries. So this MIGS and drug delivery space has been rapidly growing. 20 years ago, there was almost nothing in this area. And today we're going to talk about 18 different technologies. So we will be moving somewhat fast. So let's just review our anatomy. We're talking about mostly the trabecular outflow system is where the majority of MIGS has been centered thus far. So we're talking about affecting either the trabecular meshwork or Schlemm's canal. Now, we can also access the supraciliary or the uveoscleral outflow system. So that's this potential space here between the ciliary body and the sclera. That's a newer and a rapidly evolving area for MIGS. And then there's also the subconjunctival space, right? The traditional trabeculectomy space. But there's newer devices that are helping to make that a safer procedure. And then with drug delivery, we're talking, that's all in the anterior chamber or it's intracapsular. So drug delivery is a smaller topic that we'll talk about. So we'll start with that first. When I'm talking about drug delivery, I'm talking about intraocular sustained release drug delivery. So why would we use that? What are its advantages? Well, as you all know, compliance is one of the biggest issues with glaucoma treatment. Patients, no matter where they are in the world, have difficulty being compliant with topical drop therapy. Sometimes the drops are not affordable. There's memory issues. There's dexterity issues. Did the drop get in the eye or did it bounce off the cheek? There's different absorption rates. There's so many complex factors that go into drops and getting the correct amount of drug to the target tissue. So when we use drug delivery, so we take the drug and we put it inside the eye, that ensures adequate delivery of the medication to the target tissue. Now, potentially, not now, but my hope in the future is that this will be more affordable for patients. So imagine patients needing to come in once every few years to receive an intraocular drug delivery system instead of having to take drops multiple times a day, every day of their life. Drug delivery can also reduce ocular surface disease. As you know, that's a big deal. When you have patients on all of these drops, almost all of them get dry eye, they get punctate keratopathy, they get so much disruption of their ocular surface. All of that's negated with drug delivery. And it can also reduce other side effects. For instance, the skin discoloration that we commonly see with prostaglandin analogs. So there are currently 3 drug delivery systems that I'm aware of. In the anterior chamber, we have iDose, that's brought to the market by Glaukos. There's Durysta, and intracapsular, there's Spyglass. So let's talk about the 3 of those very quickly. So we'll start with iDose or iDose TR. So this is a travoprost intracameral implant. It was just FDA approved recently in the United States. And this is really groundbreaking technology because now you can put travoprost inside the eye for 24 hours a day, 7 days a week. There's a continuous release of this drug. You can see the device here. It's 1.8 millimeters in length and about a 0.5 millimeter in diameter. The drug is filled in this container, and then there's a filter here that controls the rate at which the drug is being released into the eye. And it has a very simple but elegant insertion system. I'm not going to show a lot of data today, but this just typically shows that the amount of travoprost that's in the iDose can last up to about 2 months. And I think in the studies we saw 18 months to 24 months worth of efficacy. So let's see what it looks like. So here is an iDose. Now, with all MIGS and drug delivery, gonioscopy is an important skill. You have to have a good view. So here I have the patient looking to the side. We've got a gonio lens on the eye, and then I'm aiming right for the trabecular meshwork. I'm going to take that barb and puncture through the trabecular meshwork into the scleral wall, so the distal side of Schlimm's canal, and we're going to anchor this iDose device into the sclera. Here I am tapping it to make sure that the fixation is secure and that it's not going to move or to migrate. I'm making sure that it's not touching the iris or it's not touching the corneal endothelium. Then we're typically doing this just with a small amount of viscoelastic in the eye. This can be used in both phakic or pseudophakic patients. So then we'll go in with a little BSS solution and we'll irrigate out the BSS. And as I'm irrigating out the viscoelastic, I'm blowing it around the iDose just to make sure it's not moving. And you can see it there without the gonioscopy view. So very promising technology that I think we'll see fairly rapid expansion into the marketplace. All right, the next one is Durysta. This was brought to the market by Allergan. Most of you have probably seen this. This has been out a few years. It's a bimatoprost intracameral implant. It is also sustained release, but this one is a biodegradable implant. So with the iDose, unless we remove it, the device stays there. So this one is biodegradable and it's providing sustained reduction of intraocular pressure. It's very small. It's 1 millimeter by 0.2 millimeters in diameter. And it's supplied with a preloaded applicator with a 28 gauge needle. And this can actually be done at the slit lamp or in the operating room under an operating microscope. So I would recommend under an operating microscope until you get adept at this. So we're going to make a clear corneal incision with the 28 gauge needle. You make about a millimeter long tunnel, and then you simply push the button, which releases or injects the Durysta implant into the anterior chamber. This implant will then fall down to the inferior angle, and it releases drug for the next 6 to 12 months. And again, because the medication is inside the eye, we see really good results because we're not having to worry about absorption through the cornea or the ocular surface. Okay, the final drug delivery device is being brought to the market by Spyglass. Now, this has not been released yet. This has not been commercialized. This is still in development. But I had to talk about it because I think this has such promising ideas to it. So this will be the world's first IOL or intraocular lens mounted controlled release drug delivery platform. They're targeting to get 3 years of drug delivery of implantable, and this would be designed to treat glaucoma patients who are undergoing cataract surgery. And as you know, there's a lot of patients that undergo cataract surgery that also have glaucoma. So Spyglass has got several drugs in development for this unique system. We go back and we look, these little pads can be filled with different medications. They are clipped onto the haptics of the IOL and then placed inside the intracapsular bag during cataract surgery. So the implantable is where I think we're starting to treat patients with glaucoma. However, there's potential to put the steroid and the non-steroidal medication that we commonly use after cataract surgery. Also, a long-term steroid can be used, so patients with chronic uveitis, and even some of the medications for wet macular degeneration can be used. So this is a really, in my opinion, exciting and rapidly developing area for anterior segment surgeons. I think that, or my hope is that over the next couple of decades, we're going to see a large transition into more drug delivery systems. So let's do our first poll question. As more technology in drug delivery is developed, how significantly will these drug delivery systems change the future management of glaucoma? This is just an opinion I'm asking. Do you think this is going to be a major change and these drug delivery systems will actually replace drops? Do you think this will be a second tier treatment after drops? Do you think this will be considered equal to drops and so patients will just be given the option? Or do you think that this is not really going to affect our glaucoma management at all? I'll give you all a few moments to log in your answers. Okay, interesting. So we have 48%, so almost half of you think that this is going to be a major change in our treatment paradigms. Only 2% thinks that this will not change our glaucoma management, and about 35% think that this will be a second tier treatment. So I think I kind of agree with the majority of you. I don't think we're there yet, but I think as this technology evolves, it's going to be a really effective way for anterior segment surgeons and practitioners to treat glaucoma, and I think we'll be able to offer our patients better results. Okay, so we have completed drug delivery. Now we're going to dive into this rapidly expanding space and world of MIGS, of minimally invasive glaucoma surgery. So if I did this talk 20 years ago, this slide would be blank. There wasn't anything there. If I do this talk a year from now, this slide will probably be a lot busier. So right now, there are 15 different procedures for MIGS that I would like to present today. We'll briefly present each one. But there's so many that are continuing to come out. There's a lot of research here. This is a very rapidly expanding area. I think that the community, the anterior segment, the glaucoma, and the ophthalmology community has realized the real value of MIGS. So we'll talk about MIGS from the perspective of ones that treat the trabecular meshwork, ones that are subconjunctival, and then ones that are the suprachoroidal space. Just as we reviewed before, there's 3 different areas that we can treat. Another way to classify MIGS procedures in the trabecular meshwork is what they do. So we have goniotomies. So this would be like a hook blade or a GAT. You have canaloplasties, which are things like the Omni. You have trabeculotomies, which I'll show you with the Elios laser. And then we have our microstents like iStent and Hydrus. All right, before we dive in, one more poll question. I would like to know my audience a little bit. How does MIGS currently fit into your practice? Are you someone who commonly uses MIGS procedures already? Are you rarely using MIGS procedures? Are you considering using MIGS procedures but still gathering information, so you haven't started yet? Or you have no plans to use MIGS? I'll give you a few moments. Okay. Oh, a really nice distribution here. So 20%, 19% saying that you're already using MIGS, about 17% saying you're rarely doing it, 50%. So half of you are saying that you're still considering it and you're in the information gathering stage. That's great. Well, I'm glad that you're here today, and I hope that this talk will help you in your journey of discovering how to implement MIGS into your practice. And we have 14% that say they have no plans to use MIGS. So I think this is really helpful information. Okay, so next is the Cahook dual blade. So this is one of the earlier MIGS procedures that came out. This is one that's very commonly used, developed by Malik Cahook and brought to the market by New World Medical. You can see the device here. It's very simple, very elegant. It has a dual cutting blade here. As you advance the Cahook blade through the trabecular meshwork, you get this bright white stripe, which is actually the backside of Schlemm's canal. So looking at the scleral wall on the backside of Schlemm's canal. Let's look at a real quick video of this. This is a Cahook blade I did recently. So again, the gonioscopy view is everything here. So you have the patient look away, you tilt your microscope, you zoom in. Here we engage the trabecular meshwork with the Cahook blade. You can see how easily it just slides along. And as you're sliding it or advancing it, you're just removing some of the or a strip of the trabecular meshwork. So I go counterclockwise first, and then I come back and I go clockwise. And what that does is that amputates that strip of the trabecular meshwork. And if you look right here, you can see that bright white stripe, and that's really what you're looking for, is that window that you've now created into Schlemm's canal. And this is technically a simple procedure that's easy to learn how to do. I think the hardest part is just learning how to get a good gonioscopy view, and you can see that white strip there. Now, you can, in low income settings, this has been reported to be done with just a 27 gauge needle, a bent needle. If you're in a setting that economically does not allow for, or it's not affordable to buy these Cahook blades. I do think the Cahook blades do a better job because of their unique design. However, there are reports and a little bit of data out there of using 27 gauge bent needles. Okay, let's talk about the Omni now. So the Omni combines two different procedures. It first does a canaloplasty. So you insert this catheter into Schlemm's canal, you advance it 180 degrees, and then as you retract it, it injects viscoelastic. That viscoelastic then dilates Schlemm's canal and the collector channels. So that's the definition of a canaloplasty. And then it also, with the same device, can do a trabeculotomy. So you advance that same catheter into Schlemm's canal, and then you just simply remove it, or you pull it back out of the anterior chamber. And by doing that, it removes 180 degrees of the trabecular meshwork. So this is what the device looks like. Very simple, ergonomically designed. You place the viscoelastic there in that reservoir in the handle. And let's take a look at a case here. So we're putting some viscoelastic on the cornea to give us a good gonioscopy view. Obviously, this case was combined with cataract surgery. So I've just finished the phacoemulsification. You can see the lens implant is in the eye. So at the end of the procedure, I'll have the patient look away from me. So in this case, I'm having them look to their left. This is the cannula here. So I always look at the cannula. I always advance the catheter just a little bit to make sure it's working before I go into the eye. I then place my gonio lens on. Now you can see the pointed tip of this catheter. So you can puncture or the cannula, you puncture the trabecular meshwork, and then you advance the catheter. And if you watch closely, that catheter just nicely expands Schlemm's canal. So if you see here, the trabecular meshwork in Schlemm's canal is very narrow, but it's being expanded as this catheter is being advanced. So I'm going to advance this 180 degrees. Of course, we can only see a couple clock hours here, but it's advancing 180 degrees. And then I'm retracting it back towards the injector, and viscoelastic is being injected. So the canaloplasty part of the procedure is being performed. And then you can see here, the catheter has now been retracted almost, not all the way back in, but back to our starting point. And now I'm just going to advance it again. So there it is, there's the end. Now I'm advancing it again. And then I'm just going to simply pull it out. And by doing that, we're doing the trabeculotomy portion, and it's removing the trabecular meshwork. Now you can choose to treat the same 180 degrees with the canaloplasty and the trabeculotomy, or you can do 180 degrees for one and then flip it around and do 180 degrees for the other. Now, each one of these MIGS devices has a nice trial associated with it. The Gemini study was the one associated with the Omni. The reason I'm showing this one is that it's a very classic representation of a lot of these MIGS devices where we're seeing pressures at baseline before the procedure, somewhere in the mid-20s, and then we're usually somewhere in the mid to high teens afterwards. And there's subtle differences to each of these MIGS devices. But the data all looks somewhat similar to that, in that we do see a nice reduction in pressure. Sometimes they're compared to cataract surgery alone. Sometimes they're compared to medications. Now let's talk about the T-Rex. The T-Rex is similar in it's doing a goniotomy or trabeculotomy. What makes this one different is that it actually has two cutting edges. So one cutting edge that will remove the trabecular meshwork, and then the distal portion of Schlemm's canal is also being opened up because theoretically there's resistance there as well. Now, this device has not been commercialized yet. It's still being refined. This is one of the earlier models, but you can see here a very similar cannula to some of the other MIGS devices. And you can see the wire retracted here, goes in and out very nicely. And so again, this one's going to do a cut on the proximal side, so on the trabecular meshwork side, just like a hook blade would do, and then also on the distal side. Now, from our gonioscopy view, it's going to look very similar because we can't see what's happening behind the catheter. But again, we're going to get a really nice gonioscopy view here. The tip of this cannula is used to puncture through trabecular meshwork. We then advance the catheter here, and as we're advancing, it's cutting the trabecular meshwork. You see a little bit of heme here, which is very common, especially because we're also incising the distal portion of Schlemm's canal. So be on the lookout for this one. It's going to be commercialized in the near future, and it will offer some unique advantages. A brand new one on the market is called the Scion, and this was just brought out by Sight Sciences. As you can tell, it looks very similar to a hook blade. Some of the subtle differences is that it's got a very blunt tip. It's not a sharp tip. So it's being advertised as maybe a softer or more gentle device. And then it also has this window here, so you can see the trabecular meshwork being removed as you do the procedure. Now, this might be one of the most important slides if having access to a lot of these MIGS devices is difficult. If you're in a low-income area, then you need to become really familiar with GATT, gonioscopy-assisted transluminal trabeculotomy. So the nice thing about this elegant procedure is that you're only using suture. So you're using a 5-0-proline suture. You melt or burn the tip of the end of it. You insert it into the anterior chamber through a clear corneal incision. And then really all you need is these micro forceps. Unfortunately, I don't have a video of this, but if you go to iwiki.org or YouTube, you can very easily find lots of great videos on GATT. but you're going to cannulate Schlemm's canal with this suture. You're going to thread it all the way around, and then you essentially pull it out. So similar to what we saw with the Omni, how when you pull that catheter out, it removes the trabecular meshwork. Same thing, but you're doing it with a very low cost 5-0 Prolene suture. So I think this is one of the best options for low income countries or countries that don't have access to some of these more expensive or cost prohibitive MIGS devices. So definitely write GAT down if you're not familiar with it, do a little research on it. And I think this is a great place to start your MIGS journey if you're wanting to offer this in low income settings. Okay, you're all probably familiar with Glaukos. Glaukos has been one of the leaders in MIGS. They brought the original iStent, which is here on the left. This iStent was placed into Schlemm's canal where these retention arches were in Schlemm's canal and the lumen was in the anterior chamber. It has now evolved a couple of times to where we're now at the iStent Infinite. So the iStent Infinite looks quite different than the original iStent. You have this rear flange. This is the part that is in the anterior chamber that we would see from a gonioscopy view. And then this conical part is what's in Schlemm's canal. And with the iStent Infinite, we're actually placing 3 of these. This is what the injector looks like. The injector works really well. I want to point out here in this far right insert the trocar. That trocar is really important when you're learning how to insert iStent Infinites. That trocar is what the device rests on. And you need to have that trocar perfectly in the center. So you don't want it biased off to one side because that can cause resistance and prevent the device from being injected properly into the trabecular meshwork. So let's take a look at one of these. Again, this is a very simple procedure. It's a procedure that can be learned quickly. So this one is being combined with cataract surgery. As now, iStent Infinite in the United States can be done as a standalone procedure, but still most of them are being done with cataract surgery. So we're going to make sure we get a good gonioscopy view again, having the patient look away from the surgeon, tilting the microscope. If you look closely in the center of the injector, you can see that trocar. We've got a moving patient here, so a little bit of a challenge to get the view. But then you take that trocar, you puncture into the trabecular meshwork, you indent lightly as you see here, and then you press the button. You hold the button and then you back out. And when you back out, the iStent is placed very nicely. Then you're going to move down 1 to 2 clock hours, ideally 2 clock hours. I didn't get a full 2 clock hours here, but if you can get a little farther, and then you repeat the same procedure, and you can see how easily this device goes in. So again, you puncture through the trabecular meshwork, you indent lightly, you make sure that the trocar is in the center, and then you press the button, hold the button, release, and you have 3 iStent Infinites adequately placed. And what we've seen is that the IOP reduction benefit is improved with the more iStents, and that makes sense, right? Because we're accessing more collector channels. So if you can get 4 to 5 to 6 clock hours covered with 3 different iStents, you're going to get better IOP reduction. All right, the next microstent is the Hydrus, also a very well-known device. This was developed by Ivantis and then acquired by Alcon. This is an 8 millimeter long microstent. It's made out of nitinol, which is a form of very flexible metal. And it covers about 3 clock hours of the trabecular meshwork. Now, what was interesting about the study, the FDA clinical trial that they did with the Hydrus, is they took patients with mild to moderate glaucoma, and some of them just had cataract surgery alone, and some of them received the Hydrus. And then when they followed them for 5 years, what they realized is that the number of patients with mild to moderate glaucoma that went on to need a more advanced surgery like a trabeculectomy or a tube shunt was cut by more than half. And that was great news, right? Because that's really what we're trying to do. We're trying to control or treat mild to moderate glaucoma at an earlier time point with more effectiveness in hopes that fewer patients need to go on to incisional or more invasive glaucoma surgery. So let's take a look at a Hydrus implantation. So you can see this cannula looks very similar to some of the other ones you've seen. You're going to take the tip of that cannula after you've achieved your gonioscopy view, and you're going to roll or slide this wheel forward, which just advances the hydrus into Schlimm's canal. You can see there's very little resistance. It slides in very easily. Now, you'll notice here that I've got about 3 millimeters of the device sticking out. We don't want to leave it that way. That can rub on the iris. That can cause an UGG syndrome or iritis. So I'm just going to take the cannula and just slide it in more. And you see how easily it goes in. So very atraumatic installation of this device, and you can titrate how far you go down. And you see a little bit of blood refluxing there from the collector channels. And again, an easy procedure to do, and great pressure reduction with that device. All right, now we're going to talk about one that's just a little bit different. So this is an ELT, an excimer laser trabeculotomy. This is developed by a company called Elios. This is what the laser looks like. This has been approved in Europe and used in Europe. We're just finishing the FDA clinical trials in the US. So it uses a 308 nanometer excimer laser, and we're essentially creating little open spots or trabeculotomy spots, 10 of them in the trabecular meshwork. And the idea is that by the laser making these spots, similar to an SLT, there's going to hopefully be less inflammation, and that these otomies will stay open longer. So this is a video from Dr. Sarkisian during the trial. So a lot of the same concept here. We're getting a great gonioscopy view as he has achieved here. This is the laser probe that's being inserted. It's a small thin probe that's easy to handle. The idea is to advance the probe over to make contact with the trabecular meshwork. Now the surgeon has a foot pedal that's controlling the laser, and the laser has a defined duration. So when you step on the foot pedal, it delivers just under a second of laser ablation, and then it stops. So the surgeon doesn't have to control that with the foot pedal. He just steps on the foot pedal. There you see the laser emission. You then move over just a couple of spot sizes away, and you do another one, and you're going to continue to do 10 of these, and covering usually about 4 to 5 clock hours. Data will be released on this in the not too distant future. So it'll be interesting to see how this works its way into the MIGS space. This is just a gonioscopy view postoperatively of some of these goniotomy spots that you can see in the trabecular meshwork. Next device I'll just mention briefly is called the iTrack. This is a canaloplasty that's done ab interno. So I don't have a surgical video of this, but very similar to what we saw with the Omni, where you have this microcatheter that you advance into Schlimm's canal. The neat thing about this is it's got an illuminated end, so you can watch the catheter go all the way around. And the unique thing about iTrack is it treats 360 degrees. So if you remember, the Omni treated 180 degrees of canaloplasty. This does 360 degrees. And as you're retracting the catheter, you're injecting viscoelastic. And this device allows you to titrate how much viscoelastic you want to inject. Another canaloplasty that's recently been on the market is called Streamline. This was released by New World Medical. This is what the device looks like. And on the right here, you see this blue tip. So this blue tip is advanced and pressed against the trabecular meshwork. When you press the button, this metal device is actually injected in through the trabecular meshwork, and then viscoelastic is injected in both directions. This is a gonioscopy view of the device. I don't have a video, but it shows the device being pressed against the trabecular meshwork, and it's injecting viscoelastic here, and you can do multiple entry points. So this again allows you to titrate how much canaloplasty you want to do. Okay, so we have quickly covered the trabecular meshwork MIGS devices. Now we will transition quickly into the subconjunctival procedure. So there's two of them. There's PreserFlow, which is being brought to the market by Glaukos, and there's the Zen, or the Zen Gel by Allergan. Now, the PreserFlow, this is not yet available in the United States. However, it is available in some countries. This has been under development for some time. So it's a 70 micron lumen tube that is approximately 8.5 millimeters long. And it is used for, so think about doing a trab. So you're going to go under the conjunctiva, but you're going to use this tube and inject it into the anterior chamber. So this is like a refinement of a trab, which is going to control the amount of aqueous that's allowed to be released. So it's going to help prevent things like hypotony. So instead of using a Kelly punch and making a large hole that allows aqueous and then trying to titrate that by suturing a scleral flap, this tube, this PreserFlow tube, is controlling the amount of outflow. And the lumen is large enough to not be occluded by epithelial cells or inflammatory cells, hopefully, but small enough to control or cause enough flow resistance to prevent things like hypotony. The Zen gel, very similar concept. Now, the unique thing about the Zen is that it can be implanted ab interno. So this is what we see on the bottom image here, where it's actually being implanted through the anterior chamber, or it can also be implanted ab externo through underneath the conjunctival space. But again, it's trying to accomplish the same thing by causing control of the amount of fluid that's coming out. You still use anti-metabolites like mitomycin C. You still have a bleb. So this is very similar to a trab. We're just trying to reduce some of the complications of a trab, making it a safer procedure, which is why it's oftentimes rolled into the MIGS category. Okay, final category of the MIGS procedures. This is accessing the suprachoroidal space. There's 3 devices that do that: the Alaflow, the Miniject, and the Ciliotech. Now, many of you might be aware or remember the CyPass that was brought to the market by Alcon, and we had lots of good results from the CyPass. However, in certain patients, there was endothelial cell loss because that CyPass might have been too far into the anterior chamber. Therefore, it was removed from the market. And then lots of companies have been hesitant to go back into that suprachoroidal space. But now we're seeing companies saying, hey, we don't have to abandon that idea. We can just refine it and make it safer. So accessing the uveal scleral outflow is a great idea because, that's where the prostaglandins act. There's actually potential for more aqueous drainage through the uveal scleral pathway compared to the trabecular pathway. So there's a lot of potential there that I think has been untapped or unrealized. So the first device is called an Alaflow. This is being developed by Ian Trek. They have a proprietary pen called a cyclopen that creates a small cyclodialysis. And then you insert this biograft, this allograft of biotissue, and this tissue holds open the cyclodialysis. It scaffolds it open, or scleral reinforces it, and allows the aqueous to continue to flow out, and has access to the uveal scleral outflow. This is what the pen looks like. It has this very soft catheter tip that's very adept at making a cyclodialysis, and then it implants the scleral tissue or the biotissue. The advantage to this biotissue is that it, in theory, is anti-inflammatory. It's scleral tissue, so it's not a piece of metal. It's seen as much of a foreign thing. So hopefully there's going to be less fibrosis, less inflammation, which will render better long-term results. So here's one of the procedures. Good gonioscopy view. Now I'm going to use the tip of the catheter here to just tease away the iris and the iris root and find that potential space between the ciliary body and the sclera, as I'm doing here. And then I advance the catheter. I'm then going to remove the catheter, but leave the piece of allograft, or that biotissue, this little strip of sclera, is going to be left there in the cyclodialysis, just like that. So here I am tapping it into place. So obviously we don't want this protruding into the anterior chamber where it could be touching the endothelial cells. We're always thinking about endothelial cell, preservation in any MIGS procedure that we do. So there's the first one. Now I'm going to take the second cyclopen with the second piece of biotissue. So again, this is donor scleral tissue. I'm going to just enlarge that cyclodialysis by another millimeter or 2. and then insert the allograft tissue into that uveoscleral space, or that suprachoroidal space. Now with this one, you'll see that it's really protruding out. There's about 2 millimeters of it. So I'm just going to very lightly tap it down, back down into place. We don't see these things migrate. We have great OCT images of them over time. They really stay right where you put them, and they do hold open this cyclodialysis. And so now that space in between the two pieces of sclera is going to remain open and allow aqueous to have access to the uveoscleral space. Okay, we're almost there, so hang in there with me. The Miniject is being developed by a company called iStar. This has been approved, I believe, in Europe, and it's undergoing FDA trials in the US. This is very similar to the procedure I just showed you. I don't have a surgical video of this, but this implant, this Miniject implant, is a proprietary material that has anti-fibrotic and anti-inflammatory properties. And obviously that's going to be really important. And I think that that's where a lot of the MIGS thinking is developing too, is more towards biocompatible tissues and materials as opposed to metallic or metal. And this is very porous. You insert it in the exact same space that I just showed you, in that uveoscleral space in between the ciliary body and the sclera that's accessed through the anterior chamber. So this is going to be very exciting to see the results of this and to watch this enter the global marketplace. This is the last device I'll briefly mention. This is called Ciliatech. This is not approved in the US. So I don't have surgical videos of this. This has been done in Europe. And this is a very unique and brilliant idea, I think. So what this is called is cilioscleral interposition. So you don't have to access the anterior chamber. So basically you take down the conjunctiva and tenons, you make a 2.5 millimeter scleral incision, 2 of them, and then you insert this device that you see here in the bottom right underneath the sclera. So now this device sits underneath the sclera, but on top of the ciliary body. So it's creating space, and that allows fluid to titrate through that space with less resistance. So you're still opening up or accessing the uveoscleral pathway, but not having to access the anterior chamber. So very possibly there's going to be some safety benefits to this. So again, let's keep our eyes open and see how this, see what the studies and the data are going to show. But I think a lot of surgeons are anxiously awaiting the data for this one. Okay, we are 43 minutes in, and we have covered very quickly 18 different MIGS procedures plus the drug delivery. And so that was a quick whirlwind there. So now I'd like to do a couple of poll questions, and then we'll enter into a few minutes of question and answer. So first poll question: which type of MIGS procedure is your procedure of choice? So if you're already doing MIGS, tell us what your procedure of choice is. If you're not doing MIGS, then if you're anticipating starting, tell us what you think you'll start with. So I'll give you just a few minutes for that. Okay, so 38% say goniotomy, 16% second, or actually tied. So we have a tie here: 38% goniotomy and 38% subconjunctival. The suprachoroidal is at 7%, and then the canaloplasty is at 16%. So that's, I think, a fairly predictable. I think for a lot of you who are already in the glaucoma space, or you're a glaucoma specialist, the subconjunctival procedures are comfortable. You're used to doing trabs. I think maybe for the pure cataract surgeon, maybe that's a little less comfortable. So those surgeons are going to migrate more towards the canaloplasty, the goniotomy, or the microstents. The suprachoroidal space, I kind of expected that to be the lowest one. It's going to be really interesting. If I do this talk again in a couple of years, it wouldn't surprise me if that one is the largest growing one as we kind of learn how to safely do that procedure and offer just another way to treat glaucoma. Okay, and then I think we have one more. There we go. One more question. This is the last poll question. what obstacles keep you from fully utilizing MIGS procedures in your practice now? So this is obviously a question that's globally oriented. Is it insufficient surgical training? Is it mostly economic barriers? So you just can't get the MIGS procedures affordably in your area of the world? Are you just not convinced that MIGS is a safer and effective procedure yet? Or are MIGS devices just not available in your country or practice setting? So tell me, what are the major obstacles for you doing MIGS procedures in your practice? And 50% say that it's insufficient surgical training. Okay, great. So that's really helpful information. So I think that that's a challenge to the global ophthalmology community to start to provide more access, and maybe industry can get involved with more access to training. It certainly is a skill that needs to be developed, but it's not, it's not that difficult. It just takes practice, like anything else. Getting into wet labs, learning how to use the gonioscopy lens. The technical skill is already there if you're a cataract surgeon. It's just learning the new variations. All right, so 40% of you are saying economic barriers, and we expected that. And I think that's a big problem. And I think that's also a challenge to the global ophthalmology community and to industry, that we really need to come up with affordable MIGS procedures, not just procedures for the high income countries, but procedures that can be done economically anywhere in the world, because glaucoma and cataracts are a global problem, and that we need to address it from a global point of view. 33% of you said that MIGS devices are not available in your country or your practice setting. So again, a challenge to the ophthalmology community and industry that we need to globalize these technologies. However, I think things like GAT or a needle goniotomy, 50 years ago, pediatric glaucoma was being treated with just a goniotomy, like with GAT, with goniotomies done with a suture. So I think procedures like that are a great starting point. I think they can be effective as the global ophthalmology community and industry work to make these MIGS devices more readily available in all parts of the world. Okay, so thank you for those answers. And that concludes the slideshow. So I'll stop sharing my screen here, and we'll go to some of the questions and answers. So if you see down at the bottom of your screen, there's the Q&A. And if you have a question, feel free to put it in here, and I'll try to get to it. We probably have about 10 minutes of time for questions. So the first question is, what is Durysta? Again, to review, Durysta is a biodegradable implant that has bimatoprost embedded in it. And so when you inject it into the anterior chamber, you get slow release of the glaucoma medication over a 6 to 12 month period. So, and it's being released, 24/7. So it's really good efficacy for controlling intraocular pressure for patients that have problems taking drops. So maybe they have surface disease, or maybe they have lots of compliance issues for whatever reason. In my practice, when patients have compliance issues, they can't get the drops in, we'll very quickly think about the Durysta because it's very safe and simple to implant. Great question. Okay, next question. You gave a wide range of duration for which the drug delivery systems work. How do you determine when exactly to reinsert a new one? And will there be a second procedure to remove the remnant of the iDose? That is a great question. So I don't think we have firm answers to that just yet. So, and it depends on the device, right? And each of these companies are trying to answer that question in different ways. So for instance, with the iDose, there are trials being done where you leave the first iDose, and 2 years later, you go back and you put a new one in, and you just leave both of them there. Comparing that to going in and removing the first one, which is pretty easy to do, and then inserting another one to get another couple of years. So I think the answer to that question is not evident yet, and it might also depend on which one, because with the Durysta, that biodegradable implant eventually dissolves, and then you can go back and do another one. Now, in the United States, unfortunately, reimbursement or what insurances will pay for are dictating a lot of that right now. but I hope that we will evolve to a point globally where we can use these medications when it's appropriate for our patients, and we can reuse them when the effect starts to die off. I also think that the newer technology, so remember, we're at the very beginning of this, and just drug delivery we're going to see a lot of growth and expansion over the next decade. I think that we'll start to see these systems get better where the drugs will last longer, to maybe they'll last 3 to 5 years instead of 1 to 2 years. The next question, which type of glaucoma surgical technique is easy and feasible for less complications for glaucoma patients? Man, that's a great question. So if we're talking about MIGS procedures, I think there's a lot of variability in which of those procedures. So a very simple way that you might start thinking about it, or kind of how I think about it, if it's mild to moderate glaucoma or more mild glaucoma, I'm thinking about the trabecular meshwork procedures, goniotomy or a microstent or canaloplasty. And because we get usually a 2 to 4 IOP point reduction with those, they're very low risk. There's not a lot of complications. There's not reoperations with them very commonly. So it's a safe, easy thing to do. Now, if the patient has moderate glaucoma, in my practice, and I'm not everybody, I start thinking more about the suprachoroidal ones, because I see a little more pressure reduction with those. But you're more likely to get things like a hyphema. You might get a little more inflammation. So that might not be right for every patient, but I at least start to think about that. And then for the moderate, heading more towards the severe, so for the more worrisome patient with a little more advanced disease, we're thinking about the trabecular, the conjunctival procedures like the PreserFlow or the Zen. So we're thinking more of a trab, but trying to modify that trab so that it's safer. Let's see what else. What other questions have? But that's a great question, and I think, and that also brings up a good point. We need a lot more data here. We're still very early on in the MIGS data, and there's not a tremendous amount of comparative studies where you're comparing one MIGS procedure to the other one. There's just so much variability, right? So there's still a lot to learn. And, I had a conversation recently with a cardiologist, and I was telling him about MIGS, and he was absolutely dumbfounded. He goes, let me get this straight. You're putting stents in the eye, but you don't know where the obstruction is. And to him, that was really crazy, because in cardiology, they do a catheterization. They know exactly where the blockage is in your coronary arteries, and they stent that specific spot. So it made me realize, we still have a lot to learn in glaucoma. Glaucoma, I think, is a very complex disease, and not all glaucoma is the same. So not everybody responds to reducing outflow resistance at the trabecular meshwork. Maybe it's farther down the system at the ureoscleral, the episcleral venous pressure. So I think we need more testing, more sophisticated diagnostics, which will then help us guide our surgical options, for these patients. Next question, what about chronic narrow angle glaucoma? That's a great question. Let me preface this. I'm not primarily a glaucoma specialist. I am an anterior segment surgeon who does cataract surgery as my primary procedure, but over 30% of my patients have glaucoma, so I've immersed myself into this MIGS space. I would say that when I have chronic angle closure and there's maybe some PAS, some peripheral anterior synechii, I have used the hook. I have used goniotomy, because you can very delicately go and tease off that PAS and open up the trabecular meshwork. Obviously, we're doing that with cataract surgery in my setting, because we're trying to open up the angle and prevent further progression of the chronic angle closure. So that's my current thing. You always want to do gonioscopy in clinic before. If there's a lot of PAS, that's going to rule out, microstents. You're not going to want to do microstents there. That's going to rule out some of the options. So I'll tend to use a hook, so I can tease away that PAS, and then I hit them pretty hard with steroid afterwards to try to prevent it from recurring. What is the approximate effect on endothelial cell count with these procedures versus the traditional ones? That's a great question. So I think that the CyPass experience showed us that we've really got to pay attention to these endothelial cell counts. So now all the FDA trials, that is, definitely being looked at. And I think what we've learned is that, all intraocular surgery can reduce endothelial cell count. We know that from cataract surgery, right? So we want to use MIGS devices that aren't going to significantly increase that endothelial cell count. And what it seems to be is that anything that gets close to the endothelium, so any device that gets close to the endothelium, can reduce the endothelial cell count. So I think that using microshunts that aren't anywhere near the endothelium, doing things like goniotomies, which aren't leaving devices behind, or canaloplasties. A lot of these MIGS devices are very safe, and most of them have not shown significant endothelial cell loss other than the CyPass. And so now we're really paying closer and closer attention to that as we develop new technologies. But so far it seems safe, and that's part of the definition of MIGS, right? It's supposed to be quicker and safer, but still effective. And I think that's the big advantage of these MIGS procedures, is they have a lower risk profile than the traditional glaucoma surgeries like tube shunts and trabs. Next question: do all glaucoma patients qualify for drug delivery? Certainly, there's contraindications, right? So I wouldn't put, say a Durysta or an iDose in a patient with narrow angles or with uveitis. Now, would we use drug delivery in uveitis with a long-term steroid like our retina colleagues do? Yes, of course. But for glaucoma, I would not. You do need to think about endothelial cells. So if you have someone with Fuchs dystrophy or really compromised cornea, that might be an indication not to do it. The ideal patient are the ones that really have trouble with compliance, ocular surface disease. Again, I think in low income settings where you don't always have great follow-up with patients, drug delivery could be great. So patients come into a cataract camp because they're blind from cataracts and they're there for cataract surgery. But during their evaluation, you realize they also have glaucoma. But you also know that this patient's going to return back to their rural setting, and the likelihood of doing ongoing follow-up for glaucoma is going to be really difficult. So that's where a MIGS procedure, maybe combined with drug delivery, could really help that patient and buy them some time. I think we have a lot to learn, but it's not going to be for every patient. Next question. Great lecture. Thank you. When do we stop the use of drops after implanting a drug applicating system? That's a great question. So in the studies, we always stop the drop. We wash the drop out. We put the device in so we can measure the device. And the majority of those patients that are in the studies for drug delivery, their pressures were very well controlled without having to take drops. Now, that's a clinical decision based on a case-by-case basis, right? So if you have a patient who's on 4 medications, that intraocular drug delivery is probably not going to replace 4 medications. It probably will replace 1 or 2. So if you have a patient on a prostaglandin and maybe a beta blocker, and you put in a Durysta or an iDose, there's a good chance that patient won't need to be on drops for 18 to 24 months if it's an iDose. So, but you're going to be monitoring their pressure as you normally would. And as long as the pressure is staying within the target range, they don't need drops. As you see the pressure creep back up, as it will over time, as the drug elution dissolves and the device runs out of medication, then you're going to have to put them back on drops. So you're still going to have to monitor them. Again, I think as the technology develops, we'll hopefully get longer lasting drug delivery systems, and we'll see just much longer duration of great pressure control. Okay, I'm going to take this one as the last question, because we are at 10 o'clock. It's been an hour, and I know everybody's excited to get their weekends going. So this question is a great one. Can you combine different MIGS procedures in a single setting? Does it give better pressure reduction? Absolutely. So that's being done much more commonly now. And you can combine all different kinds. So for instance, you can do an eye stent on one side and a canaloplasty or a goniotomy or trabeculotomy on the other side. You could even do a trabeculotomy on one side and then do maybe an Alaflow or a ciliary body or supraciliary procedure on the other side. So yes, you can combine them. In the US, that's been slow to evolve because of the economic environment. The insurance companies won't always pay for the combined. But if you're in a setting where your care is not being dictated or influenced by insurance companies, you certainly can combine them. And we're seeing that evolve in the literature. And I think that combining MIGS procedures and even drug delivery procedures can get you closer to the efficacy of, say, a trab, or maybe not a tube, but a trab where you're getting more and more pressure reduction. And those studies are slowly starting to come out. And I think we're going to see that as the future of the MIGS space. A great question. All right. It's been an hour. This has been a lot of fun. I really hope that this has been helpful for you wherever you are in your MIGS or drug delivery journey. I do hope that that we all agree that MIGS is here to stay, and that's going to continue to become a bigger part of our practice, and it is going to offer safer options to our patients that have glaucoma. And who knows, if we do this talk again in a year or two, it'll probably look a lot different, and we can look back at this one and say, wow, look how far we've come. But please feel free to reach out, and I wish all of you a happy and prosperous weekend. Thank you. Signing off.